Hello, my name is Mohammed. Welcome to another session of CT Scan Academy. In this lecture, we'll cover the practical physics parameters used in CT imaging, with examples and practical tips for the Philips Ingenuity 16-slice CT family. We will discuss kilovolts per centimeter, milliampere seconds, DoseRight, the Philips automatic tube current modulation, positioning considerations, collimation and detector configuration, and practical workflow tips. Please listen as though this is a step-by-step guide for protocol optimization and dose/image quality trade-offs. Kilovolt peak stands for kilovolt peak and represents the maximum voltage applied across the X-ray tube. It controls the energy spectrum of the emitted X-ray photons and therefore has several direct effects on image appearance and dose distribution. Photons have higher energy and greater penetration. This reduces beam hardening artifacts and moves dose deposition deeper into the body, reducing skin dose. The trade-off is lower image contrast, particularly with iodine contrast. High kilovoltage peak is therefore preferable for large patients or dense anatomy, for example, pelvis or skull base, where penetration and artifact reduction are important. Photons have lower energy and less penetration, but higher contrast, especially for iodine-enhanced studies such as CT angiography. At lower kilovolts per centimeter, the photon energies are closer to iodine's K-edge, approximately 33 kiloelectron volts. So contrast enhancement appears stronger, HU values increase, and vessels are more conspicuous. The trade-offs are higher image noise and a relatively higher surface dose because more energy is absorbed superficially. Choose kilovolts per centimeter to balance contrast, noise, and dose. Remember, HU values are kilovolt peak dependent and not strictly comparable across kilovolt peak settings. Typical recommendations: 80 to 100 kilovolts peak for many CT angiography exams to improve vessel contrast, and 120 to 140 kilovolts peak for large patients or dense anatomy to reduce beam hardening artifacts. In abdominal pelvic CT, use 120 to 140 kilovolts per second when imaging without contrast, stones, and calcifications, and 80 to 100 kilovolts per second when contrast differentiation is critical, vascular and soft tissue contrast. It directly controls the number of X-ray photons produced. More photons mean lower image noise and better low-contrast detectability. Fewer photons mean higher image noise and lower patient dose. High MAs reduces image noise and improves low-contrast detectability, useful for obese patients or exams where fine contrast resolution is required. But increasing MAs increases patient dose. Importantly, noise reduction is not linear. Doubling MAs reduces noise by about 41%, so doubling MAs is not a proportional improvement. Low MAs increases noise and may reduce diagnostic performance for low-contrast lesions, but reduces dose and is useful in pediatrics and dose-sensitive patients. Practical MAs tips: tailor MAs to patient size, anatomy, and clinical indication. Beware of scanner phenomena that add dose without image benefit. Overbeaming, extra radiation outside detector width, and overranging extra radiation at the start/end of helical scans. Automatic tube current modulation helps optimize MAs, but cannot eliminate overbeaming or overranging entirely. As you can see, when the milliampere seconds, or MAS, is increased, the radiation dose also increases, and when the MAS is reduced, the dose decreases accordingly. DoseRight is designed to keep image quality consistent while reducing dose. Important points. DoseRight varies milliampere dynamically while keeping kilovolt peak constant. It uses the Scout SurView image to estimate patient density and thickness, adjusting milliampere up for dense regions, for example, shoulders or pelvis, and down for less dense regions, for example, thorax. The aim is to achieve consistent image quality with reduced dose. Accurate patient centering in the gantry is critical. If the patient is off-center, the system's estimation of patient size will be wrong. Even 3 to 4 centimeters of miscentering can cause 20 to 30% dose error. Too high centering makes the body look larger and causes MA overestimation and extra dose. Too low makes it look smaller and may cause underexposure and noisy images. Accurate patient centering at the gantry isocenter is critical for DoseRight and other automatic exposure control systems to function correctly. Off-centering influences the apparent patient thickness on the SurView and can produce substantial dose errors and inappropriate milliampere modulation. Always check centering and ensure a good quality SurView before scanning. DoseRight mechanisms includes Z-axis modulation. MA varies head to toe. Angular modulation. MA varies during rotation to account for lateral AP thickness differences, and a reference milliamperes per second set by the operator to define the target image quality. An incorrect reference results in systematic over- or underexposure. Tips and limitations. DoseRight optimizes dose, but does not guarantee uniform noise across all anatomies. Its accuracy depends on a high-quality SurView, correct centering, and an appropriate reference MAs. Philips Ingenuity Flex 16. Specific notes and algorithm rules. DoseRight works only if enabled during protocol creation and uses the SurView to estimate water equivalent diameter WED. If a dual SurView is performed, only the first SurView is used for DoseRight calculations. MA's recommendations from DoseRight depend on the selected kilovolts, reference WED values, about 33 centimeters for adults and 20 centimeters for pediatrics. If a patient's WED differs by plus or minus 10 centimeters from the adult reference, verify MAS manually. For pediatric patients with WED greater than 25 centimeters, approximately 50 to 90 kilograms, DoseRight may be disabled. Algorithm rules. Practical rule of thumb. For every 5 to 6 centimeters above the reference WED, the algorithm doubles MAs. For every 7 to 8 centimeters below, MAs is halved. Clinical uses and limits. DoseRight is suitable for abdomen, pelvis, thorax, and spine imaging. It is not appropriate for head scans, quality assurance/calibration scans, continuous CT protocols that require specialized timing, brain perfusion studies, or bolus tracking. DoseRight optimizes dose but may not provide uniform noise in all cases. Operator judgment is still required. Here you can see that DoseRight is activated with a fixed kilovolt per milliampere seconds, or MAs. If the MAs is manually decreased or increased beyond the system's calculation, DoseRight becomes deactivated. Collimation defines the X-ray beam width at the detector level and therefore controls the raw data thickness, Z-axis coverage. In multi-detector CT, it determines how many detector rows and what width are active. Philips Ingenuity. Flex 16 detector configuration. The scanner has 24 physical detector rows, 16 central rows at 0.75 millimeters, and 8 edge rows at 1.5 millimeters. Common acquisition modes include 16 times 0.75 millimeters, 12 millimeter coverage, 16 times 1.5 millimeters, 24 millimeter coverage, 8 by 3.0 millimeter, 24 millimeter coverage, 4 by 4.5 millimeters to 18 millimeters coverage. The chosen collimation limits the slice thicknesses that can be reconstructed. For example, 16 times 0.75 millimeter collimation allows very thin reconstructions, as low as approximately 0.8 millimeters, suitable for high-resolution CT, HRCT, and CTA, while 16 times 1.5 millimeters generally restricts reconstructions to greater than or equal to 2 millimeters, suitable for routine abdominal or chest studies. Therefore, select collimation that matches the clinical purpose and anatomy. Effects of collimation size: narrow versus wide narrow collimation, 16 by 0.75 millimeters. Pros: enables thin slices, approximately 0.8 millimeters, high spatial resolution, excellent for HRCT, CTA, bone detail. Cons: increases image noise, may require higher MAs, higher dose, produces much larger data sets and heavier reconstruction storage needs. Wider collimation, 16 by 1.5 millimeters or 8 by 3.0 millimeters. Pros: lower noise per slice, faster scanning, reduced dose per rotation. Cons: reduced spatial resolution and potentially missed small lesions. Less ideal for fine 3D reconstructions. In every protocol, you can see the different collimation options that are available for that specific protocol. For example, in this case, only 2 collimation choices can be used. When we select a narrower collimation, we are able to reconstruct thinner slice thicknesses. On the other hand, when we select a wider collimation, the reconstructed slice thicknesses are larger. Therefore, when designing or choosing a protocol, it is very important to consider this point and match the collimation to the clinical purpose of the examination. Acquire thin slices to preserve maximum detail, then reconstruct thicker slices for routine review to balance noise and storage. This approach preserves diagnostic information while keeping everyday review manageable. Effective slice thickness, practical summary: 1 millimeter slices. Highest spatial resolution, best for small structures and high-detail tasks, e.g., HRCT, CTA, but greater image noise and larger data volumes. 2 millimeter slices, a compromise. Improved signal-to-noise ratio compared to 1 millimeter, still reasonable spatial resolution for many diagnostic tasks. 5 millimeter slices, lower noise, shorter reading time, reduced data storage and transfer requirements, but lower sensitivity for small lesions. Choose the slice thickness according to clinical need. Use thin slices for acquisition if you may need high detail, and reconstruct thicker slices for routine interpretation to reduce noise and workload. I'm really glad you joined me in this session, and I hope you now have a clearer understanding of the practical physics of CT. To watch more sessions, don't forget to subscribe to our channel and give it a like. Don't forget to share what you think about this video and the ones coming up in the comments below. I'd love to hear from you.